to The Spill, Season 2, Episode 4. On today's episode of The Spill, I'll be speaking to a medical professional about the use of epidurals during birth. So please stay tuned. And thank you so much to our sponsors, Nature's Discount Nutrition Center, your health and wellness store, Adams Healthcare, and Cohen George of Caribbean International Group.
I visited Nature's Discount at 7 Great George Street in Roseau, where I had an interesting and informative conversation with staff about weakened immune system and ways to strengthen, change one's lifestyle and diet. They recommended supplements and teas explaining what each is good for. As I browsed, I noticed vitamin, herbal, and mineral supplements, sports nutrition, men's, women's, and children's health products, dairy alternatives, healthy snacks, herbs, whole fruits, and more. Pay a visit or call 440-0175.
At Women's Health Plus, we offer presentations on health topics, particularly women's health topics. We also offer private and group consultations for women who just want to better understand and manage some of their health conditions. So feel free to contact Women's Health Plus using the information below. Welcome to The Spill. It is so great to have you on with me today.
It's an honor to be here.
And it's the first time I have a relative on The Spill, so of course it's an added bonus.
Yes, cousin.
that I was able to have you on. Jenny and I am interested, and the audience is interested, I'm sure, in what is it that you do? What do you do as a job?
Well, full-time, I am what's called a CRNA, and that stands for Certified Registered Nurse Anesthetist. Mm-hmm. And basically that means that I'm an anesthesia provider. And I provide different forms of anesthesia depending on the patient's medical history or like type of surgery, and in different areas. So like OB, endoscopy, in the OR where we do various surgeries. Mm-hmm. And while I'm on that, like a lot of people confuse CRNAs with anesthesiologists. Okay. And wonder what's the difference? And some people refer to me as an anesthesiologist, but mm-hmm. we're all anesthesia providers, but anesthesiologists go through medical school, whereas CRNAs go through nursing school and then go on to get an advanced degree in anesthesia. So with CRNAs, you're trained to practice independently in every form of anesthesia, but mm-hmm. whether or not you are able to use all your training depends on where you work, the state that you live in, because I'm trained in the US, mm-hmm. Or like the type of setting and the hospital that you're in. So there are different, whether you work independent or whether you're supervised by an anesthesiologist, there are different setups.
Okay, so right now, what area are you based in at the hospital that you work?
So I do everything. Okay. Yeah, so I do OB, where I do epidurals or spinals for patients coming in for deliveries. Okay. I work in the operating room, so I do a lot of general anesthesia where you put people off to sleep. We do, hips, orthopedic surgeries like hips and knees and, mm-hmm. Different things like that. And I also work in endoscopy where we do sedation cases for people coming in for things like colonoscopies or okay. upper scopes. Yeah, so I rotate around. Okay,
all right. But of course, this is The Spill, mm-hmm. and we discuss women's health issues.
Right.
And something interesting is that you work in OB.
Right.
And I was interested in finding out about women and giving birth mm-hmm. and the whole aspect of anesthesia mm-hmm. as a part of their birth plan.
Right.
So tell me, what women need to consider. A pregnant woman mm-hmm. who is going to give birth and wants to have a successful birth, what do they need to consider for their birth plan? From your perspective, of course.
So I'm happy that you said successful birth, mm-hmm. because I think that's something that a lot of people take for granted. And they don't realize that even if you're pregnant or even if you come in to have a baby, you may not necessarily leave with a baby, mm-hmm. or even like partners may not necessarily leave with their partner, like the mother. So people really need to, I think, the first plan is, the first thing is for people to really keep the goal like at focus. You need to have healthy mom and healthy baby. And sometimes that does not involve having like a regular vaginal delivery, whether it's with an epidural or without. You have to be able to be flexible when considering having. You can have a plan, but just be flexible, because at the end of the day, the role of the medical people is to make sure that you leave healthy with yourself and the baby. And also, we also have the issue of like, people they come with preconceived notions. So, maybe like your mom, maybe had all her babies natural. So she'll be like, oh, you can go ahead and just do this, you can do it or whatever. But people have to realize that is your birthing experience, and pain is very subjective. So maybe your mother could have tolerated the pain, but probably you can't. And that's okay. Maybe your mother had small babies, but your babies might be big. The position of the baby can cause, delivery to be more difficult, and you may need some type of pain relief. So just, yes, it's good to have a plan, but just know that there might be deviations, and that's okay. It's just, you just want to live with your baby, and you want to live healthy to be there for your baby.
And you said something so interesting, rebirth, and, people comparing maybe what their mother did or what all their aunts did or their sister did. And I think maybe traditionally or culturally, we have a thing about, being strong women. And so all the women, normally give birth without any assistance. So that's what I'm going to do. And
right.
We kind of hold that very near and dear to us. So I felt it was rather, interesting or important that you said that each experience is different.
And I will add too that people don't take into consideration the length of labor. So whereas some people may have precipitous labors, they may, labor for like a couple hours or like 8 hours. Your labor might be 24 hours and 36 hours. So can you imagine being in pain for that long? You need some rest so that you can be able to deliver the baby, Right. So that's something else to consider. And maybe you may need some type of interventions just to give you a little break.
I haven't been through it, but I can imagine.
Right.
The need for a break. So you mentioned that you administer epidurals.
Yes, I do.
Tell me a bit about this epidural, something that I've always, been fascinated about, something that is much discussed among women. Like, do you have an epidural? Do you not have one? What are the risks? So tell me about the epidural. What really is it? How is it administered?
Okay. And I don't know what's, to be honest, if that's readily available here. But in terms of an epidural, it's a form of pain management for mainly with what I do. Obviously, I do OB. So it's for women coming in for deliveries, but you can use epidurals for other types of things too. But I'll just focus on the OB aspect of it, obstetrics. So basically, it is where, we we numb the area so that way you don't feel too uncomfortable. Most people describe the sensation as pressure after you numb the area. And it's put into the lower back, and you insert a needle, and then through that needle, you insert a catheter, and that catheter stays in place. And so you use that catheter to administer medication. Usually there's a pump with medication that is just infusing continuously. So no matter if your labor is 2 hours, 8 hours, or a little longer, you're continuously getting that medication. And what the medication does is it decreases the intensity of your contractions. So you may feel some pressure sometimes, especially as the baby starts to descend, but you don't necessarily feel that like the uterine contractions. So it's really nice when you put in an epidural, and then you can see on the monitor the contractions. So like, I'll just be talking to the patients, and then I'm like, did you feel that contraction? And they're like, what contraction? So then I'm like, okay, that's my job's done.
Okay, but of course the uterus is still contracting and pushing that baby,
right
out as it should.
So everything is still working. It's just that the message to the brain that there is pain is not happening.
Right. So what about the risks of having an epidural, and of course the benefits too? Let us discuss that.
Okay. So with anything, there's risk. And so it doesn't come without a risk, honestly. We have measures in place to ensure that we try to be as safe as possible. And anesthesia has come a long way. So, epidurals are considered to be very safe now. And there are a lot of myths out there. Yes. A lot. People come in all the time, talking about all these things that they're afraid to get an epidural for, the reasons. But, in terms of risk, the main ones I would say, like after you put an epidural, there's a risk that your blood pressure could drop a little bit.
Okay.
This is stuff that we anticipate. And so what we do is before we place an epidural, we always fluid bolus, meaning give IV fluids, like a certain amount to the patient before we administer. So they're optimized. Hemodynamically. So we do that to try to offset it. But if, let's say, your blood pressure does drop, we have ways we can give you medications to bring it back up. It's an easy fix, honestly.
Okay.
The other one that's a big one is it's called a postural puncture headache. And I will probably explain more, because it gets, I don't want to get too technical,
right.
but basically you can get a headache with epidurals if it is done where you kind of puncture a membrane called the dura, which you don't want to do.
Okay.
Now, obviously, when you're trained to not do that. But, there's always a risk with everything. So it can happen. It doesn't happen very often. It's very rare. But if it does happen, what happens is that the spinal fluid is kind of leaking out. So it just causes you to get a headache. And we do have ways that we treat it also. It's not fun, but we can treat it.
Okay.
So these are the main two that I tell people about.
Interestingly though, Janine, there's a lot of talk about possible puncture of the spine and paralysis.
I knew you were going to say that.
Yeah, so tell me about that. Is that a myth? Is that
that's
true?
A big myth.
Okay.
So in terms of paralysis, to paralyze someone, you pretty much have to sever a nerve. And that it would be very difficult to do. I mean, you would have to, the patient would be screaming, pretty much if you were trying to go through a nerve,
Okay.
And in terms of research, it's not to say that it can never happen because anything is always possible. You get in your car, you could be in a car accident, that kind of thing. But you have a higher chance of being in a fatal car accident than getting a paralysis from an epidural. I think there was a study that was done, and I think the incidence was 1 in 240,000 or something like that. It's a huge number. So it's pretty rare for that to happen. Another myth, we're kind of getting into the myths, but another myth that people talk about is back pain. They're like, I don't want to get an epidural because, this person said they had back pain and so forth. But honestly, according to the American Society of Anesthesiologists, there is no evidence to link epidurals to back pain. Okay. Because even with studies that have been done, people who get epidurals or don't get epidurals, they do experience back pain, So there's not a statistically, it's not that evident that it can be a clear-cut thing, definitely. Because you have to consider that your body is going through a lot of changes. You're growing this human being over the course of these months, and your bones are shifting. A lot of people experience what's called lordosis, where your spine kind of curves. Okay. So all of those things happen, and nobody takes all of that into consideration. Okay. But then they blame the epidural. Okay. So honestly, there is not... Right, it's a scapegoat. So honestly, there is not research and evidence that gives clear-cut that yes, it's going to be you're going to have back pain.
All right.
There's always a risk of infection, but we do it under sterile technique to prevent that. So we know what the risks are, so we do things to offset that.
Okay. Yeah. Benefits though.
Benefits. The main one is pain relief.
Right. Right.
I think childbirth is one of the most painful things that any woman will ever go through in her life. And once you get an epidural, it's amazing to see the transformation in a woman who's experiencing pain from laboring. After she gets an epidural, it's a different person. So I normally joke around and say, I don't take anything that people tell me personally because they're a different human being under pain. So I'll meet you after we have the epidural, and that'll be the real you.
Okay.
Yeah. So, pain relief is the main one. Another thing is it decreases your stress, it decreases your anxiety, because obviously pain brings about those things.
Right.
It gives you the opportunity to rest because, you're laboring you don't know how long you're going to be laboring for. So you get a chance to rest so that you have energy to push. Unfortunately, some women experience vaginal tears or, and they need some type of repair. So the epidural can be maintained, the infusion can be maintained whilst it's being repaired. So that also helps with the pain there. Another good thing about epidurals too is that if, let's say, somebody's laboring and then for some reason they're failing to progress, so the baby isn't, they can't deliver the baby vaginally, and so we have to shift and then do a C-section. We can actually use an epidural for a C-section.
Oh.
Yeah. So what you would do is you would at that point you have to change the drugs and the like the concentration and stuff, because you have to be able to meet surgical needs now. It's not just laboring needs. So you just have to dose it based on a C-section, and we can also use the epidural. And the great thing is it's already in place, so the patient doesn't have to undergo another procedure to yeah. So
okay, and we're segueing nicely into C-sections, which I wanted to speak about.
Okay.
In the last episode of the Spill, we had 2 women who had multiple pregnancies, and we spoke a bit about C-sections, but I want to get a little bit more into it as it relates to how do you numb the area for the C-section to proceed. So what is the process that the woman has to undergo to have a C-section?
Okay. So if somebody comes in for a planned C-section, so we know they're going to have a C-section, basically, as long as everything, because we always do a pre-anesthetic evaluation to make sure they're okay for the anesthetic, typically we would perform what's called a spinal. And a lot of people mistake the what is an epidural versus what is a spinal. No, we go in through the same, like it's placed in the lower back also. But if I can just, in layman's terms, so there's a membrane called the dura, because like epidural. When you're putting in the epidural, you go in through the back and you want to stop just before that membrane to put the catheter that I spoke about. Okay? Now, when you're doing a spinal for like a C-section, what you want to do, it's a much smaller needle, but you actually want to puncture that dura to go in, because on this side is the spinal fluid, which you want to get to. So what you do is you infuse medication in, and nothing stays in their back. So whereas with the catheter, with the epidural, there's a catheter that stays in place. With the spinal, there isn't. So we put the medicine in, everything comes out. It works really quickly because it's in the fluid that's going to help to numb the nerves. The patient feels numb from like the nipple line down, and we can go ahead and start our C-section. It's really quick.
How long does the medication last?
So anywhere like 2, 3, 4 hours. So it gives us enough time to get the C-section done, and also it provides a little bit of pain relief after, which is welcomed because you've just had surgery. So we use a spinal for in those cases. I mean, I did mention before we could use an epidural for C-sections, but that's if you've been laboring and stuff. If you come in for a planned C-section, we would never put an epidural in. Yeah, because it's a longer process too. So.
Any complications can arise
with the spinal?
With the spinal?
Yeah, I mean, it's pretty much the same complications that could arise with epidural. With the postural puncture headache that I mentioned earlier, it is less common because this time we actually wanted to puncture that membrane that I spoke about that you don't want to puncture. And the needle, because we're puncturing the membrane, that needle is really small. So the incident, it can happen also, but the incidence of these headaches it's really rare.
And have you ever, been witness to or had to see complications with delivery itself? Whether vaginal or C-section, complications that maybe could have been avoided if there was a pain intervention. I am wondering about that.
So with vaginal deliveries, generally I'm not present because I would have put the epidural in, and as long as I've done a really good job, then they don't need me anymore. Yeah, they don't need me anymore. Sometimes they might call me and tell me to turn down the epidural because it's so good that the patient they're not feeling any sensation to push. So I might have to turn it down a little bit. Sometimes I may be called to give a little extra because, they might be a little bit uncomfortable or whatever it is. But generally during vaginal deliveries, I'm not present. But during C-sections, I'm present from beginning to end. So whether I'm using the epidural or I'm placing a spinal, I would be there doing that. And then I would, dose the epidural or place the spinal. And I'm with the patient the entire time doing the monitoring. In terms of complications, I would say one of the things that, I wouldn't really call it a complication, but it's just, you don't want that to happen. But sometimes, again, people perceive pain so differently. They might be uncomfortable. A lot of times it's like after the baby comes out, and they're doing all their repairs and getting everything back into place. Sometimes the patient might be uncomfortable. They might get anxious. And because they're awake, I should mention that during C-sections, you're awake, typically. There are times you're not, but we're not discussing that. But typically you're awake if you have an epidural or spinal. So sometimes for some patients, they get really anxious, because they think of what's happening and they are worked up. So as an anesthesia provider, I can be able to provide medication to help them relax. But usually I do this after the baby's out because I don't want to give anything in their IV that could affect the baby. So I will give them medicine to help them relax or to address the pain. And that's typically that's one of the things, or I can give them stuff to help them kind of like just drift off to sleep just a little bit, like a little snooze, you know? Mellow them out.
Right.
Yeah.
And that's interesting, not wanting to affect the baby, because I know maybe that is a concern of a lot of women when we speak of pain management.
Right, it is.
During birth and delivery. So, what's going to happen to the baby? Is that okay for the baby? I know that is maybe, a primary concern.
And I probably should have mentioned that, but when we consider putting in medicine in that area with the epidural or the spinal, by the time the medication is metabolized and goes through the system to cross the placenta to get to the baby, it is so minimal, it's not significant. To be honest, I think the baby would get more by giving them IV medicine. You know what I mean?
Okay.
So, yeah. But again, so many myths. That's why I really encourage people to be their own advocates and to do the research. Don't just repeat what your grandmother and your mother and auntie and your partner is saying. Yeah, you need to do your own research.
And with so many changes and so many things, available. I mean, you mentioned you don't know what's available in Dominica. I mean, the audience is Dominican mainly, but audience spans, different countries. But a lot of Dominicans go overseas to have their babies. A lot of Dominican women. So, I mean, this might also apply to that, because you're going somewhere where there may be options that you don't have here. And, considering those options carefully is definitely something you need to do. So, and that brings me now to this whole concept or argument that people often have, redoing everything natural and, natural birth, natural delivery, natural everything. I don't want any kind of medication, versus the whole use of an epidural or of, some pain management. I want your take. I feel I know your take, but I want your take on this argument, because it's something that I hear frequently. And I also even hear one group shaming the other and vice versa, so there's a lot of talk around that. So tell me your take.
So to start off, I think the fact that there's even an argument is ridiculous. Because I think, as I said from the beginning, the goal for me is to have a healthy mom and healthy baby. And when you're walking on the street with your live baby, it doesn't matter what happened, whether you used an epidural, you had to get a spinal, you did a vaginal delivery, you had a C-section. It really doesn't matter. At the end of the day, you have your baby in your arms, and that is the most important thing, because I've seen many cases where that's not the case. People have had to leave the hospital without their baby. So that's the first thing. Like, it's not a conversation that I can really take a part in, because I get a little... I could be a little heated, because to me, it's not important. Like, it's a very personal decision. If you want to have an unmedicated delivery, that's fine, and if, let's say, you're able to go through with it, great, good for you. If you walk into the hospital and you decide from the get-go, even from the time you get pregnant, you're like, I want an epidural, that's fine. Some people do opt for C-sections for different reasons. That comes with its own complications, which I'm not here for. But, as long as your doctor deems it's okay, it's fine. You know what I mean? So to me, it shouldn't really be an argument. I think what really kind of, I don't want to say gets to me, but it's really unfortunate is if, let's say, you have like people in your ear, kind of telling you, well, you should do this natural. So you feel like the pressure to do it natural, even if you want to have some type of relief or some type of, telvention. Because probably we have situations where the spouse is saying, oh, you can do it. And, I'm like, you're not the one in labor. Or, you have like, family members, telling the spouse, yes, or the partner, telling them they can do it or what. And, they're miserable. And I mean, and it's not really like the first thing that they would want to do, but then they're kind of pressured. Because at the end of the day, you don't get a badge. There is no badge that you're given for doing it natural. It doesn't matter, like if that's what you want to do and you go through with it, great. But it's fine if you don't, and you have to do what's best for you. And sometimes you might decide to go natural, but then eventually we have to change things. Because let's say you have to have a C-section at that point, you're definitely getting drugs. We can't perform a C-section natural. Or your baby might not be coming down. Or maybe your baby is not in the correct position for delivery and it is so painful, you realize I can't take this anymore. Because we have so many situations when people come in and I'm on for OB, I see all patients. Whether or not you tell me you want one, you don't want one, I see everybody and I get a pre-anesthetic evaluation, because I can't tell you the number of times people don't want to talk to me, they don't want to see me.
And they end up
But then they
having to
call me and they're like, I can't take it anymore.
Right.
So, I mean, and that's fine. Sometimes they don't call me and that's okay. But at least, you know, I always tell them I'm there 24/7, so we're available. And
You sound like that stone the builder rejected.
yes, for real, for real. And you know, you can't
Cornerstone.
you can't walk in and be unprofessional and be like, I told you so.
Right,
But you know, you come in and you just do your job and hope you do a great job, you know? Yeah.
And I think, your take on this is important. I think we have the same sort of arguments, breastfeeding.
Oh, yes.
So many different things as women, what is the right way to do certain things. And, as you said, there's no badge.
There is no badge of honor
that you get, for making your choice.
Yeah.
So I take that. I appreciate that. And as we wrap up this interview, Janine, I know, you're a CRNA and you work at the hospital, but I know you also have a private business. So I wanted for you to just tell me what else you're up to.
Well,
apart from what we just discussed.
Well, I guess I'm not busy enough. So I decided to start an aesthetics business. And basically, I do things like what people consider Botox and fillers. And I do, but it's all medical grade, So facials, but it's medical facials. So with microneedling, I use your blood. If you research, you might see things called vampire facials. So basically, I use your blood, the plasma part of your blood, to do microneedling facials. I do chemical peels. I do sell skincare products, also all medical grade. It's not stuff that you can get over the shelf. And I also do I have a machine, equipment that I can use to help get rid of stretch marks or tighten the skin or So I do all of that, and it's myself and my husband. He does the business, I do the clinical. Okay. Yeah.
And so your clientele, I guess, is primarily women.
Yes, primarily. I have a few male clients. Okay. Yeah, it's really nice to have a few males, but primarily women.
Yeah. So this is definitely another women's health topic as well. But getting those fine lines.
Oh yes, wrinkles. Yeah, I mean we all care about our beauty, you know. So. It's called Latouche Elite Aesthetics, by the way.
Okay.
Yeah.
So Janine is available if you're ever in her area.
I know.
Get you yourself beautified. Janine, thank you so much for joining me on this spill. I appreciate the time that you took to speak with me on this spill, and I really hope that someday we will be back doing a grander interview on a bigger scale. But thank you so much for this interview.
And thank you so much for having me. This was actually very fun.
Thank you.
Thanks.
I visited Nature's Discount at 7 Great George Street in Roseau, where I had an interesting and informative conversation with staff about weakened immune system and ways to strengthen, change one's lifestyle and diet. They recommended supplements and teas, explaining what each is good for. As I browsed, I noticed vitamin, herbal, and mineral supplements, sports nutrition, men's, women's, and children's health products, dairy alternatives, healthy snacks, herbs, whole fruits, and more. Pay a visit or call 440-0175.
Thank you so much for viewing this episode of The Spill. If you liked this episode, and I know you did, please share so that your friends and family can get a chance to view it too. Thank you so much to our guest for joining us on this episode and sharing her professional experience with us. And thank you to our sponsors, Nature's Discount Nutrition Center, your health and wellness store, Adams Healthcare, and the Kerwin George of Caribbean International Group. Remember, Women's Health Plus. Like, share, subscribe. you.